Hey, all, welcome to this very special episode of Real Life Pharmacology. Before we get to that, please go sign up. Real Life Pharmacology will get you emails out when we've got new podcasts available. We can also get you a free PDF on the top 200 drugs. It's a 31-page PDF, no brainer for you to have there. Also, this episode is sponsored by meded101.com, so go check out their resources there for pharmacists, pharmacy students, med students, nursing students, all the links there at meded101.com/store. Go to directly support this podcast and what we're doing to try to help educate healthcare professionals. So I hope you enjoyed this episode, and definitely feel free to reach out to me, Eric Christensen, mededucation101 at gmail.com, if you have any comments, questions, or concerns. Here's the episode. All right. Well, I'm excited today. I've got Beth Zerr with me. So this will be a unique episode of the Real Life Pharmacology podcast. And she's been gracious to give up her time to answer a few questions regarding asthma and sharing her experience. So thanks for being with us, Beth. If you want to give us a little bit of background on yourself, that'd be greatly appreciated.
Sure. Thank you for having me. First of all, I got to work with Eric many, many years ago when I was a student. So this is kind of fun coming full circle here. Currently, I work as an assistant clinical professor at the University of Arizona. I teach various pharmacotherapy classes for students. I also teach the self-care course, and I'm almost afraid to say that I teach asthma because that means I should do a good job here today, but that is what I teach our students. I also have a clinical position. I've worked at AmCare for the past about 14 years. Right now, my clinical position is all telehealth, and I focus on mostly diabetes, hypertension, lipids, kind of the common things.
Perfect. Sounds good. Well, we'll get right into it. That's what I like to do. So I really enjoy sharing some of the things from the real world. I know a lot of students benefit from that, learning what actually happens out there in practice. So from your perspective and your practice, what are some of the most common questions surrounding pharmacotherapy and medications that you get from patients, and then kind of working your thought process through on how you address those and tackle some of those?
Yeah, I think asthma is one of those disease states where it's not as obvious why you should be treating it every day. Kind of like hypertension, like taking a medication for hypertension every day, a patient might not feel different when they take it. So same with asthma. If I have patients who aren't having difficulty breathing, it's harder for them to understand why they need to still be taking their maintenance inhaler every day. So that's probably one of the most common mistakes I see, is that patients kind of tend to fall off using their maintenance inhalers when they're having a period of good breathing. So the way we address that is really just patient education and making sure that patients understand the reason why it's important to always be treating your asthma. So talking about that underlying inflammation component, trying to stay on top of that, and talking about how even in mild asthma, you can have serious consequences from any exacerbations. Patients seem to understand the idea of remodeling when you talk about how anytime you have an exacerbation, it can lead to scarring in the lungs. It's kind of a good way to talk about it for patients. So anytime you do that, then you make your baseline breathing a little bit worse. So that's the reason why they need to stay on those maintenance inhalers. So I'd say understanding the reason why you got to keep treating it even when you're feeling good is one of those most common questions from patients.
Yeah, and that definitely ties in a little bit, I think, with common mistakes that patients make. That's certainly something that I have definitely seen. In your experience, do you feel that is more maybe a cost issue of the medication as a whole? Because obviously that's a major issue for sure.
Oh, I mean, you can't talk about asthma drug therapy without talking about cost. And you're right. Sometimes it is kind of a value judgment of, I'm feeling good, so I'm going to make this 1 month inhaler last 2 or 3 months if I can. And that brings up a good point about really meeting patients where they're at and trying to find the most cost-effective meds when you can, and remembering to step down therapy when you can. So maybe a patient does have an opportunity to use their inhaler less if they've been well controlled.
Yeah, exactly. Does that go through your thought process? If you have a patient that comes to you and said, I'm doing okay. I haven't really taken my inhaler for 2 or 3 months. I mean, is that in your thought process of like, okay, do they really need it?
Oh yeah. I mean, and that's every time I'm talking with students and we're talking about how we're taking care of asthma, it's not only ramping patients up on medications, but it's evaluating them every time they come in. If they've been well controlled after 3 months, guideline directed therapy is to step them down or to attempt to step down. And I think that's something that practitioners miss at times. And it can be one of those areas where meds get added and added and added and never taken away, even when the patient could be appropriate for that.
Yeah, and even my thought process with geriatrics, like I don't think about deprescribing as much with asthma, and I think that's a great point. I mean, 3 months isn't that long of a time frame,
Yep.
to think about that de-escalation. So that's definitely something I could probably be more diligent about in addressing with patients. So no, that's a great point. So any other common mistakes regarding maybe specific inhalers or medications or anything else that way you could think of?
Oh, for patients, it's always administration. You can never underestimate how many times and how many different ways you need to talk about the administration of different inhalers. And not only is it difficult to use, say, an MDI or a metered dose inhaler, but then most patients likely have two different kinds of inhalers. So they have an MDI and a DPI, a dry powder inhaler, and those require totally different techniques to use. And if that's never been explained in a way that a patient can understand, then they're not going to use those inhalers, right? Those medications aren't going to get to the lungs where they need them. They're not going to be effective. So reviewing administration, not just on the first time, but literally every single time that you talk with a patient about their asthma medications.
Yep. And I've definitely felt that as well. I probably deal with COPD a little bit more in the things that I do in my practice, but my first thought when somebody is failing, is not doing well on a therapy, is like, hey, go back, review, like, are they actually taking it the way they're supposed to be? So
oh yeah, I could not agree with you more.
Yep, exactly. So if you have somebody failing, go back, start from the beginning, make sure that they can probably afford their medications like we talked about before already, and then B, making sure they actually know how to use them too. Insurance formulary stuff. Do you see patients juggling a lot? Does it happen on an annual basis when they change coverage, or what's your practice like in that situation?
Yeah, I'll say I am pretty spoiled in my position right now where I deal with a set number of insurance formularies. So very comfortable with the formularies. We know what to prescribe that's going to get covered, kind of know the tricks for our patient group of what to get covered. But what you mentioned about when formularies change over every year, that's the biggest issue, is that we often see different contracts happening. So maybe they were contracted with this drug company and now with a different, so we have to switch all the inhalers over to the new drug company. It's frustrating. So all the new covered meds, and again, it's not just switching the inhalers, it's whole new techniques because it's the new devices as well.
Yeah, and that's totally something I think that flies under the radar too, where it's like, oh yeah, okay, we can get through that, we can switch them to a new one, or whatever, but like, who's doing the education piece and making sure that gets done? So definitely a big challenge there. How about common mistakes made by young pharmacists, young nurse practitioners, PAs, physicians? Anything that jumps out at you there as far as asthma care?
I might have covered most of it already, but I really do think, and maybe this is just my bias, but I think educating patients, we have to spend more time doing it. They need to understand not only like how to use their meds, but why they need to use their medications. Most of the time when patients are what we'd call like non-adherent, it's not because they don't want to be healthy, it's because they don't understand that what they're doing isn't the best for them. So for example, like not taking your maintenance inhaler, they might not understand why that's important for them to do. So new practitioners, any practitioners actually, just need to make sure that their patients understand so that they buy into why treating their asthma the way that we're recommending is important. And then like another little caveat on that is making sure they understand the difference between maintenance and reliever inhalers. Because it seems obvious to us because we're talking about them all the time, But knowing that, yeah, taking this Advair is not going to help my breathing right away, like this albuterol is, but letting them understand why that is and why they're both important.
Yeah, exactly. Let's switch gears a little bit. Let's talk a little bit about medications. I've been asked the question regarding drug interactions and what do we need to worry about if it's inhaled med, anything like that. The beta blocker one is one that I've had students ask me quite a bit. What's your thought process? Do you worry much about those inhaled meds and any drug interactions? Anything there relevant that you think is important?
If a patient is doing well on their current therapy and they're on, say, an interacting like beta blocker, with a beta agonist, I don't usually spend too much time changing medications if they're well controlled. If we do have a patient who's is having concerns, then that might be a time when I'd look at changing medication to try to avoid the interaction. But I do not see it commonly in practice where it's actually clinically significant for my patients. That's the other thing I was gonna think sorry, I lost my train of thought.
That's okay. No worries. And I know like you see it on interaction programs once in a while where it's like, this inhaled steroid goes through CYP3A4 and it's like how is it clinically significant?
That's what I was gonna say.
Yeah.
You always have to think about how much absorption are you getting from medications. So interactions, sometimes they're talking about systemically absorbed medications, and you got to look at how much of that inhaled med is getting systemically absorbed. What kind of realistic interaction would we expect?
Yep, exactly. Good points there. Adverse effects. What do you see in your practice regarding obviously inhaled corticosteroids are the mainstay maintenance therapy there, but then we can add in beta agonists. Do you see more or less challenges with either of those meds and causing maybe some of the systemic adverse effects?
So probably the biggest one I talk about with my patients is more with the pediatric group and the inhaled corticosteroids with concerns for growth.
Sure.
Because there is risk of it's I'm trying to remember what the studies were saying, but it's fairly small, but there is a risk of decreased height when we're using inhaled corticosteroids chronically in our pediatric population. But there is more data out now that shows that we usually do recover that growth as the drugs are stopped. So say as our pediatric patients may grow out and not need those inhaled corticosteroids anymore, almost all of that growth is recovered. So there's long-term data showing that it's not a long-term effect for most patients. So talking about that with parents who may be concerned about some of those side effects can be important. Other side effects like bone density, things like that, not as concerning just because we know that there's less systemic absorption. It's not the same as taking an oral inhaled corticosteroid. I know that thrush gets talked a lot about, or oral candidiasis with use of steroids. That one's kind of controversial with some of the more recent data. You can always recommend that a patient do like the rinse and spit after they use a steroid inhaler. But there's been studies that have shown that it makes no difference on the incidence of thrush. So I can tell patients about that, but if they don't feel like doing it, I'm not too worried about it. Yeah. Other side effects, beta agonists, we always talk about tachycardias. If I have a patient who's coming in and they're having like some anxiety tachycardia associated with their beta agonist, the first thing I'm going to do is ask them how often they're using it, because it may be more of an overuse thing than just a plain side effect from the drug.
Yeah. Yep. Exactly. Especially the cheaper beta agonists, they potentially would be more likely to overuse.
Or our OTC.
Yep. Definitely. So, no, that's a good summary there. You ever see any excessive shakiness and stuff, or is it mostly increased heart rate?
Tremor.
Yeah.
I haven't seen too much in practice with patients that are using it appropriately.
Gotcha. Yep. Sounds good. All right. What's new? Guidelines, medications. I know we had the GINA update a little while back. How has that impacted your practice?
So there's been like a fundamental shift in the way that we treat asthma, with GINA updating in 2019 and then NHLBI followed suit in around, I think it was 2021 when they updated their medication use guidelines. Basically, there's a push to have inhaled corticosteroids used in mild asthma. So, and it can be part of a daily regimen or even PRN. So we can have our mild asthma patients who used to be treated with just PRN SABA products, treated with PRN combo ICSI-SABA. And then the reason behind that is that there's data showing that even if you have mild asthma and you have a rare risk of exacerbation, when you do have that exacerbation, you have just as much chance of having like a very severe reaction, ending up hospitalized, than our patients who have more of that moderate or severe asthma. And what can prevent that is having some of that anti-inflammatory drug on board. So again, push for earlier use of anti-inflammatory medications, specifically the ICSIs. It's a slow curve to change practice because this is a big change.
Yeah, that's definitely what I was going to ask you I know I've seen it some, but I've also seen some patients just have their PRN albuterol and that's what they do too.
Yeah, so I know I didn't mention this to you before, but I'm working on a project right now with a pharmacy resident where we did a research on our system group, looking to see what has there been a change since the guidelines have been updated. And in the health system that I work with, we still find about 2/3 to 75% of patients are on the updated guidelines of having an inhaled corticosteroid on board. So I would say it is starting to shift where we are. But it's a big opportunity for pharmacists, especially pharmacists in the community setting. If you see a patient filling just a SABA inhaler, kind of talking to them about, have you been back into your provider? Have you talked to them about the updates in asthma treatment? I think that's a good opportunity for pharmacists to be involved.
Yep, for sure. Do you are you comfortable leaving them with the albuterol and just adding on the inhaled corticosteroid, or are you trying to get them to, the budesonide formoterol, product, for example, where it's like, okay, it's just one inhaler to worry about, or are you just kind of seeing where they're at and then going from there?
So the guidelines, GINA really focuses on the Symbicort or the budesonide formoterol product, and the NHLBI gives more leeway. They just want an ICSI involved. If you can get a patient to just have one inhaler, that makes so much more sense, right? They have one device that they have to use. They can use it as needed and as their maintenance, or they can just use it as their as needed. So if I have insurance covered for a budesonide formoterol product, I'd prefer that.
Yeah.
But the other option is if you have a patient who already has both those like both an ICSI and a SABA, then just kind of teaching them to use them together can be good too.
Yep. Yeah, exactly. So I am actually kind of surprised that you said 2/3 to 3/4 are on.
So were we, to be honest.
Yeah, which is great. I mean, it definitely, tells you that
part of it in the real world might be that we don't have enough patients that are getting classified correctly with mild asthma.
Okay, gotcha.
Or those patients are getting coded as like respiratory distress as opposed to mild asthma. There's lots of system issues there about how you get counted and quality measures. But
exactly. So let's talk devices a little bit. When are you kind of looking for spacers? Are there devices that you would prefer to see used over others? Some that are easier for patients, some that are harder. Give us a little rundown on devices and where the role is there in asthma care.
Sure. My favorite device is the one that's covered the best for the patient and that they can afford to use. But then after that, like if I'm in the real world or like in the imaginary world where I can pick any device, the Ellipta devices are so easy to use for patients. If you have arthritis, they're larger. You can, they're easier to manipulate. There's really just open the slot, breathe in the medication. There's very few mistakes you can make with those. I think the only one is really like covering the vent with your finger, but that's actually kind of hard to do when you're holding it. So if I have an option, I use those. I also, when I'm thinking about devices, if there is an option to have a patient all on the same type of device, so either like all elliptas or say all dry powder inhalers or all metered dose inhalers, I try to do that. And it is possible now because our SABAs are available in dry powder and metered dose inhaler devices. So you can get someone on a reliever and a maintenance med where they only have to learn one inhalation technique. So I think that's important for patients. It's less things they have to think about when they're trying to use their meds. And then I think you asked about spacers, and anytime you have an API, spacers have been shown to improve drug deposition into the lungs. So if a patient is open to using it, a spacer is always a good addition. They're just not as convenient. So I'd rather have the patient take the med than not take it at all because they refuse a spacer. But talking about spacers is important. Yeah,
exactly. And then, kind of summing up a little bit, are you seeing any of the oral medications utilized much anymore? Montelukast, things like that?
I see Montelukast. I don't see much else in my practice. But again, if I have patients who are in the more severe category, they're usually referred to a pulmonologist. So it might just be where I'm working. Yep,
exactly. So definitely a lot of new specialized biologics out and things of that nature too, that I see that keep coming, which is good, definitely. So more tools for people to use there. So with that, I'm not going to take any more of your time. Any last comments, things you want to emphasize, and then maybe how people can contact you if they've got questions regarding ambulatory care practice and things of that nature?
Yeah, I mean, my comment on any drug talk is always that pharmacists can make a huge difference with patients because we've got a lot of education that we can, impart to patients and help them understand why we want them to use their medications the way that they should and why that helps them be healthy. So don't underestimate the power that pharmacists have in any setting, including our community setting. And then as far as contacting me, you can email me at Zerr at arizona.edu. So
awesome.
Zerr at arizona.edu.
Awesome. Thanks so much, Beth, for being with us. Hopefully this was a nice new little format for the Real Life Pharmacology podcast. And hopefully you guys picked up some practice pearls today. So thanks again, Beth. We appreciate it.
Thank you.
Hey all, I hope you enjoyed this episode today. Please support the sponsor if you're looking for NAPLEX study materials, ambulatory care, pharmacotherapy, geriatrics, BCM, TMS, exam study materials. Go check out meded101.com/store, support the sponsor, and help keep this podcast free and educational for all to enjoy. If you're another student, we've got all sorts of different books, crossword puzzle books, case study books, drug interaction books. All those links you can find at meded101.com/store. Thanks for supporting the sponsor. Please do us a huge favor, give us a rating review on iTunes or wherever you're listening as well. Thanks so much, and I hope you have a great rest of your day.